Hello, Dr. Darty here with some ideas from Chapter 3. This may be somewhat shorter than previous lectures, but we'll review some of the high spots. Once again, your review questions and the PowerPoint that I've prepared to go with Chapter 3 are probably your best bet for deciding how to spend your study time. Let's start by noting a fun fact. Dorland's Medical Dictionary, which is a classic, most people who go into healthcare are required to have it or end up buying it, has currently 125,000 entries of medical terms. Clearly, in AHS 115, we are not going to learn all those terms. Dermatology, along with ophthalmology and perhaps pathology, maybe neurology, but dermatology certainly has more than its share of those 125,000 terms. There are certain specialties that just love their words. Dermatology is one of them. So the folks who were assigned to write Chapter 3 for you faced a really daunting task. They decided, apparently, to divide Chapter 3 into a basic discussion of the skin and its structures and its basic functions. Then they moved on to talk about, in the next section, let me go back, excuse me, some terms about treatments and problems that the skin can have, including words used to describe symptoms of skin conditions, the appearance of skin conditions. They went on to note the difference in an infection and infestation. They talk about fungal infections. They talk about skin malignancies. There's just a great deal of information in Chapter 3. If I were you, I would sort of direct my study to looking at the words once again in the tables marked word analysis and definition. Do your review questions, have a look at the PowerPoint, and I'll try to hit some of the spots here that might be a little bit confusing or the ones that are the most important. Some of the terms that are introduced to you in Chapter 3 are not unique to dermatology, but can be applied to the practice of medicine as a whole. A few of those you probably know already, or at least have a pretty good idea of what they mean, but I thought we'd hit some of the most important ones right off the bat. First, I think everyone knows what a diagnosis is. We might express it differently, but it means what's really wrong, or what do we think is really wrong. So if I go to the doctor and say that I have a sore throat, the diagnosis would probably be pharyngitis. That's just doctor speak for an inflamed throat. If I had a strep test and it came back positive, indicating that I had a streptococcal infection, then that diagnosis would be further defined, clarified to be streptococcal pharyngitis. So a diagnosis is the correct medical explanation, or at least our working explanation, for what's wrong with the patient or with the patient's body. Prognosis means what do we think is likely to happen if the patient has that diagnosis. So for some things, like a common cold or upper respiratory infection, the prognosis for any of us should be good. We would anticipate a complete recovery. If I were treated for my streptococcal pharyngitis, we would expect that I would recover from that in a few days, and the prognosis would be very good. There are some problems, however, where the prognosis is not so good, where the patient is expected, sadly, not to do well. And we hear about those in the news all the time. I think everyone's aware that currently the prognosis for most, if not all, Alzheimer's disease patients is not very good. The prognosis for glioblastoma multiforme, a type of brain tumor, is pretty grim. The prognosis, sadly, right now for ALS, amyotrophic lateral sclerosis, or Lou Gehrig's disease, in today's world is not very good. It's good to remember, however, that some diseases that in the past had very grim prognoses, things like childhood leukemia, now, with appropriate treatment, have a very good prognosis. And a prognosis does not mean what's certain to happen, it means what's likely to happen given what we know about that patient's condition at the time. We've heard a lot about that with COVID, things that would indicate a good prognosis and things that indicate a more serious prognosis. So, diagnosis, what we think is wrong; prognosis, what our best, it's not a guess, our best information about what can be expected to occur with that diagnosis. Another thing that gets a little confusing is the difference between symptom and sign. Unfortunately, they both start with the letter S. A symptom basically is what the patient tells you they are experiencing. So if I came in and said again that I have a sore throat, that is a symptom. A symptom of a sore throat is sore throat. Or I have a runny nose. Now the doctor might write that down as rhinorrhea, but it is a symptom. A sign is what can be objectively seen by a healthcare provider. So if I go in and say, gosh, I have this itchy rash, and the doctor looks at my arm that's itching and says, well, you have erythematous macules, red spots, that would be a sign, what can objectively be documented. Not all signs have to be visible. A sign can also be what you learn from a lab test or an x-ray or some other type of study. But generally, when we say symptom, we mean what the patient is expressing as their discomfort or problem, their concern. And a sign is what, when we look at the person, we can actually see. Again, some leeway there. That leads us to the difference, and it really sort of piggybacks on this, of the difference between subjective and objective. When you write notes about a patient, you usually begin with the subjective part. Sometimes that's described as the chief complaint. So if you go to the doctor and you say, I really have, my stomach hurts, that is your chief complaint, stomach hurts. Objective might be that when the doctor palpates your stomach or your abdominal area, that patient is sensitive to palpation, it means it hurts when I press, or the doctor might listen with the stethoscope and note there are no bowel sounds present, that's not good, or that there are hyperactive bowel sounds present, your stomach is really gurgling. Again, that's an objective finding. If the nurse took your vital signs before the doctor came into the room, your temperature, your respiratory rate, your heart rate, how much you weighed, those are all objective findings. They're facts. Subjective is what the patient reports to you that they are experiencing. So those are all important things. Now, to get more specific about skin, it's interesting that most of us don't really think of our skin as an organ in the same way that we think of our liver or our kidney or our heart as an organ, but skin is actually our largest organ. On an average sized person, it weighs about 9 pounds, but since it's spread out all over our body surface instead of being in one neat little chunk, we tend not to think of it as an organ. But like all of our body organs and organ systems, it has a lot of important jobs to do. Obviously, it acts as a barrier. It keeps things out that we don't want in there. That's why we get concerned when we're cut and don't want it to be infected, because a breach in that skin is a gateway for bacteria or fungus or virus to enter our body, and we don't want that. It also is a protective barrier, keeping things that belong on the inside from going on the outside, particularly our body's fluid component, our water, literally. That's why we worry about burn patients who've lost a lot of their skin becoming quickly dehydrated, because the main thing that keeps your moisture, your vital water inside your body is your skin barrier. Another important thing that your skin does for you is it helps to keep you warm. If you've worked at all or know anything about burn patients, if a patient has lost a lot of skin, one thing that happens is their body temperature can plummet very quickly. That's why we often cover them with a Mylar blanket. That's also why if you have a very thin body type with not much fat in the layer right under your skin, your hypodermis, you tend to get chilly, whereas a person who has a thicker blanket of adipose or fat surrounding their body may feel warm in the same environment. So it does act as an insulator. Our skin also contains the organs that allow us to touch, to have a sense of touch. So when someone, again, has lost a lot of their skin and that's been replaced by scar, they often have a lack of sensation in the areas that have been damaged and then covered over by the body's healing mechanism that's not really the same as the original skin. There are a lot of other things. Your skin makes the precursor of vitamin D. Your kidneys get in on the act later, but you don't need to worry about that. But when exposed to sunlight, your skin plays a vital role in allowing your bones to use the calcium from your diet to make a stronger bone. So vitamin D from skin is an important thing. Also, your skin can cool you in warm weather because it contains sweat glands that put moisture on the surface of your skin, and as that moisture evaporates, as sweat evaporates, it takes heat with it and you're cool. So your skin is really important, and the doctors who take care of that, as you know, are called dermatologists. The fancy word for your skin and its associated structures, your hair and your nails, is the integument, and we say the integumentary system to include skin, hair, and nails. Now, if you look at the tables in your book, there are quite a few terms, and I thought I'd just highlight a couple of those that might be confusing. One of the words is biopsy. You've heard that before. And for a dermatologist, that might be taking a tiny little bit of skin. For a specialist in another specialty, it might be taking a pretty good chunk of an organ so that it can be examined microscopically and determine exactly what's going on with that particular organ. You may know the term carcinoma, which means an invasive tumor. It's one type of tumor. That's all of these are on page 37. At the bottom of that table, and again, this is something that's often evident in your skin but is important throughout your body, are two terms that you should know: vasoconstriction and vasodilation. Vaso clues us in that we're talking about a blood vessel, and constriction means exactly what you'd think. It means a blood vessel becomes narrower, becomes smaller. If that happens in your skin, that there's less blood flowing to your skin, to the surface of your body, you'll look pale. On the other hand, if you have vasodilation, meaning the blood vessel gets bigger, you might appear flushed or red. So vasoconstriction, if it happens anywhere in the body, means blood vessels narrowing. Vasodilation means blood vessels widening. An important term not just for dermatology. On the next page, on page 39, there are a lot of terms that deal with the different layers of the skin, and this is pretty straightforward. Most sources consider the skin has two layers. Some people include a third one we'll discuss in a second. But the top layer of skin and the thinnest is your epidermis, and that's what you see. That's how you know I'm an older lady, because you can tell that I have the changes in my skin consistent with a woman in her 60s. If you looked at a picture of me when I was in my 20s, you'd see that my epidermis looked different then. Right under the epidermis, you find the thickest layer of the skin, the dermis. And that's where most of the action is, where your sweat glands are, where your oil glands are that secrete sebum. They're called sebaceous glands. That's where the blood vessels, a lot of the nerves of your skin are there. So the connective tissue that makes your skin tough. So most of the skin's thickness is in that second layer. And you have a very nice illustration for that on page 38. You might take a look at that. Now technically, the tissue right under those two layers, most sources don't consider it a proper part of the skin, but it's still important. It's called the hypodermis, and that's where we find the adipose tissue or fat that I was mentioning earlier that helps to insulate us. So if you think about a term you've probably known for a long time, a hypodermic needle, that tells you that we are going all the way through the epidermis with that needle and through the dermis into the hypodermic layer, perhaps even the muscle under that. It's a deeper injection. If you do an intradermal injection, and you remember that intra means within, that would be like a TB skin test, where we just want to inject a little bit of material right there in that layer under the epidermis. And we can see a little bump or bubble where we did that skin test. So that's an intradermal injection. So that should help to clarify some of those terms. At the very bottom, they mention one of the first words that we use for lumps and bumps, and it's wheal, not like a wheel on a car. It has W-H-E-A-L. And that basically means a swelling. Usually, we mean like a little hive-like swelling, but a wheal means a bump that shouldn't be there. Now, there are a lot of other words for bumps that we don't want to be there, and some of those are found on succeeding pages. A papule means just a little, typically a little round bump. A vesicle, only one S in vesicle, a vesicle means a blister, a fluid-filled bump on your skin. And it can be tiny, like chickenpox vesicles, or it can be quite large if you've worn shoes that don't fit properly and gotten a big blister on your foot. You also see blisters with burns, but the correct term for a blister is a vesicle. A vesicle that's filled with pus is called a pustule, and that's seen, say, in smallpox, or if you get a splinter, you might have a pustule from that. See, I had a couple of other ones I wrote for that. I think that's most of those. Pigmentation of the skin, how much melanin or skin pigment is there. If you have skin that gets darker than normal or than it should be, that's called hyperpigmentation. Actually, I don't know if you can see it. I burned my arm last week. Maybe you can see it if I turn it just right. Just a little superficial burn taking a hot pot out of the stove. And it's healing nicely out of the oven. But you can see that that little skin lesion I have there for the moment is hyperpigmented. If I had a spot on my skin that had less pigment than we'd expect, that would be hypopigmented. An example of a hyperpigmented lesion is what we commonly call a mole, but which the dermatologists call a nevus. And I won't read to you every one of these terms. You can enjoy looking at them yourself, and you can enjoy doing the review questions that highlight the ones that we think of as most important. So let me know if there are any that are confusing. If you'll contribute those to the discussion board, the general discussion board, then I'll be happy to offer, I hope, a clarifying example or a more exact description. But in the meantime, just have a look at the words that are used to describe various dermatological conditions. And if by the end of doing that you aren't a little bit itchy, and the word for itchy is pruritic. We call itching itself pruritus. If you aren't a little bit pruritic, that means maybe you didn't read it all. So I'll check back in with you for Chapter 4. Let me know if you have problems. You have my email address and you have the discussion board. Thanks. It's Dr. Daugherty signing out.